home health care spending was through the roof. There was a sense in which the culture of medicine had gone to an extreme that we don't want to approach as a country. The startling thing to me is not that this was McAllen, Texas. It was that they were basically following the incentives of our healthcare system to its logical limit. And the remarkable thing is that other places haven't done it yet. We could become a place that is like that unless we change our incentives to be about not more care but better care. If we don't think hard about the kind of care we want to deliver, which includes what are the things that we want to have at the bedside, and also if we aren't thinking about our culture of medicine, which can be corrupted.
Well, explain what it is that caused this major difference just between, for example, McAllen and El Paso. What you discovered were these incentives for some of the most expensive health care in the country, I think, which shocked people all over the country, in McAllen, Texas. Yeah,
and the surprising thing was that the incentives were not remarkably different there, but you had you had some members of the medical community who started to recognize the opportunities. So you had a large, you had for-profit hospitals, large physician-owned hospital. You had fragmented, disorganized care, and so what that meant, and then you looked in certain pockets like mental health care. It's low profit, it gets neglected. Primary care, again, not as, what you saw were big cardiology centers, orthopedic centers, the parts of medicine that we want great cardiac care, we want great orthopedic care, but not at the neglect of the whole system of care that was missing.
So the doctors were making more money there?
They were. I don't have the numbers, but let me put it this way. One of the stories that I tell is of the contrast, and I talked about Grand Junction, Colorado, or the Mayo Clinic, where you could have higher quality care at much lower cost, and how it actually is possible in our country. A third of the places are delivering this. One of the things that you see in those places, the care is better organized. They actually work on making sure that inappropriate care, even if it makes high profit, doesn't happen. And when the article was written, teams from McAllen actually went to visit one of the lower cost places, which I see as part of what reform is about, changing things. But one of the folks in Grand Junction, Colorado, called me up to say, you wouldn't believe it, but these doctors arrived in a private jet.
I mean, you point out that the Mayo Clinic doctors are on salary. That's
yes.
a massive difference.
It is. And one of the things that we don't know is a salary doctor, we know, doesn't have the incentives to just do more and more and more. On the other hand, we've seen that a salary doctor could be someone who goes home at 2 o'clock because, hey, the day's over and I want to go. We've seen systems, though, where they have doctors who are even on salary and have created higher quality care, hardworking organizations that really provide extraordinary care. I don't know if the answer is switch everybody from fee-for-service to salary. What I do know is that we need a different way of paying doctors than the piecework kind of way we've got. And the reform bill that's now under consideration, for the first time, actually starts to tinker with that system to say, we will give incentives to places that begin trying new ways of paying doctors and testing them for both the effect on reducing costs and its effect on improving quality.
And I think one of the most startling things you write in the article is that not only do they do these unnecessary tests, but it can actually be harmful to the patient. More testing can actually result in worse care.
Yeah. When we are now a country that does over 50 million operations a year. I'm a surgeon. I like doing operations. But when you start doing more than 50 million operations a year, you better be sure, for a country of 300 million people, you better be sure we're doing the right ones. And we know in certain pockets of care we're producing more surgery than we should. And if you do excessive amounts of surgery, we have major complications. We have right now over 150,000 people who die as of complications of surgery, die within 30 days following surgery. And we know at least half are avoidable. If we are able to think harder about making sure we're providing the right care in the right ways and avoiding overtreatment and mistreatment, we're likely to actually be better about saving people's lives and improve our cost picture considerably.
And you talk about incentives and having a correct system in place. Do you think that private insurance companies have a place in healthcare in this country? I mean, they have a legally obligation to increase their profits, and that almost necessarily implies denial of care. There seems to be an inherent conflict of interest. How do you resolve that? Do you think we should get rid of private insurance?
One of the things about my article about costs was that I found myself almost not having to think about or not addressing insurance at all, because whether it's Medicare or other public health government programs or private insurers, none of them have figured out how to keep our costs under better control. It really has to do with the decisions that doctors and patients make together about, do I get a scan for this headache? Do I get an operation for this back pain? For my 85-year-old father or mother with dementia but a tumor, should we take it out or not? Those questions are fundamentally medical. I don't think insurers, public or private, are likely to be the source of the solutions. But what I can tell you is that as we go through reform to remove their ability to cherry pick on pre-existing conditions or shove people out of care, it forces this key question: what is the value added by having private insurers? The only place it can be added is if they are working to improve care and control costs, work that hasn't been done in a significant way on either side.
And you also talk about the Massachusetts plan. Can you explain what that is?
And I've been living through it. The Massachusetts plan has, we had 12% uninsured 2.5 years ago. We adopted a bipartisan plan that allows people to get a choice of private insurers, and it actually doesn't look that different from the reform plans going through now. That choice of insurers, you can go online and pick up coverage that's subsidized so that nobody pays more than 8% of income, and if you're poor, it's free. That provision of insurance has changed things dramatically in the last 2 years. We have only 2% uninsured. It's like many European countries now. The people in the state haven't really noticed it. And the claim that this is going to bust the budget of the state just hasn't come to fruition, no matter how much the blogs say one way or the other. The data are that health costs in the state have risen at the same rate as in other states. And in this recession, we didn't have the bottom fall out from our families under it. The cancer patients I had to take care of, where we spent half our time trying to figure out how to get them coverage, I haven't had that happen in 2 years.
I wanted to get your comment on one of your colleagues, Dr. Steffi Woolhandler.